I love that Sarah Rickham actually said that the placenta doesn't turn into a pumpkin at midnight. And so I've been very heartened over the years, because this is one of the most read articles on my blog, to have private message and emails from people saying that what I'd written, that lots and lots of professionals share it with their client, but also couples who are pregnant and who were facing induction of labor, like coercion around induction of labor, said that my writing helped them feel strong enough to stand up for what they felt was right for them.
Hello and welcome back to another episode of the Birth Lounge podcast. All right, you guys, if you have not taken the opportunity to download the Birth Lounge app, let me stop you in exactly what you're doing, exactly where you are, and point you to your app store. Whether you have an iPhone or an Android, we're in both of those app stores, and this is quite possibly the best app you can have in pregnancy. Not only does it bring you the latest, most up-to-date, evidence-based information about all of the choices that you need to make in your pregnancy and throughout labor, but it also has your week-by-week growth and development of your baby. And let me tell you, it's not some silly fruit comparison. It's truly what is going on with your baby's body and within your body. We're talking about, like, when does vernix start to form? When is your baby's gastric system up and running? How can you tell that they are having the expected and appropriate lung development? What should you really be seeing in terms of fetal movements, and how do you actually keep up with your baby's well-being in the womb? This is a transformational app. It is going to teach you pain relief measures. It has information on baby aspirin, preeclampsia, advanced maternal age, epidural use, induction, C-sections, unmedicated birth, birth tools you're definitely going to want to pack in your hospital bag, and postpartum tools that will make that transition easier. Forget the apps that say, hello, your cute little bean is the size of a peach. Heck no. I want you to know exactly what that heartburn is for. You're growing toenails and eyelashes, baby. All while staying empowered to make the biggest decisions in your pregnancy, like gestational diabetes testing, whether or not you're going to do genetic testing, what will you choose for your method of testing for gestational diabetes, and are the antibiotics for GBS appropriate for you? Not only is all the data linked right there at your fingertips, but every single evidence-based article also has questions that you can take into your provider to ask them so that you can start this discussion of collaborative, respectful care. Because I don't just want you getting respectful care from your provider. I want you to be an active participant. I want you opening up this line of communication to let your provider know not only are you informed, but you're educated about your options, and you want to be kept in the loop about the decisions made around and for your body and baby. Head to your app store on Android or iTunes to download the Birth Lounge app right now. All right, speaking of being empowered and making big decisions, have you ever been told that your placenta is going to get too old or expire, or maybe that your placenta stops working after a certain date? Well, that's exactly what we're tackling in today's episode. The myth of the aging placenta. So, is it true? Does your placenta know the day that you turn 40 weeks? Is it going to magically just crap out on you? Do you run the risk when you have a big baby that your placenta has to work harder and is less likely to work efficiently post due date? I'm so lucky to be being joined by Sophie Messager, who bridges worlds that rarely meet. She's a former reproductive psychologist with a PhD who then traded her microscope for doula work. And that's where she's been practicing for more than a decade. Her unique combination of scientific expertise and spiritual insight allows her to serve as a compassionate space holder for those seeking to merge their analytical and intuitive sides. Today, we're going to dive into how this myth, completely fear-based and almost wholly made up, impacts your autonomy as a birther, and how it also impacts your decision making by instilling fear in you when it's just simply false. Sophie's not only going to share the research, but we're going to talk about the questions that you should be asking your provider to really get down to the bottom of it. Like, can you show me the specific evidence that my placenta is no longer functioning well? What kind of tests and procedures can you have your clinical care team run to determine the efficiency of your placenta health? And don't worry, you know we're going to tackle the topics of advanced maternal age, IVF, and all the other things that the healthcare system might throw at you in an attempt to get you to believe that your placenta is just going to magically stop working one day. Sophie is such an advocate for getting evidence-based care into your hands, and that is how I knew she was perfect to have on the show to talk about this exact topic. So without further ado, you guys buckle up and grab your pen and paper because you're gonna want to take notes. Sophie, welcome to the show.
Thank you very much for having me here. I'm really delighted to talk to you about this. This is a really important topic close to my heart.
It really is. And it's one of the things that feels very unknown to a lot of people. We know that we have a placenta inside of us. We know that it's the lifeline to our baby, but other than that, a lot of women don't know very much about their placenta. And if you're watching on YouTube, you guys, you can see the placenta up here. I love the placenta. It is one of the most fascinating organs, and I find her to be very feminine because only women will have the placenta, and I just love her so much. I think she is one of the coolest things that happens during pregnancy. And I think that hearing your placenta is getting old, your placenta is going to stop working, your placenta is going to crap out on you, can be so scary because we know that it is the lifeline to our baby. And that's really what I want to tackle today. I want to tackle how do we navigate the hospital system in the birth world when we're being told fallacies like your placenta is going to give out, as if our placenta has access to a calendar inside of our uterus. But before we do that, I think I'd love to know, why are you here in this realm? What got you started in the idea of the aging placenta?
It was, so to backtrack a little bit, I was a scientist, I was a biology research scientist for 20 years, and my PhD is in physiology of reproduction. So when I became a doula, started training in 2008 and started working as a doula in 2012. I realized quite quickly that what you take for granted is what the stuff you do easily, which is analyzing research. I know you do that too. I started realizing that I had something that I could help a lot of people with. And the reason why I ended up writing this particular piece was because I kept noticing that a lot of my colleagues on forums where they were both medical professionals and doulas kept being bamboozled by people in the medical field who kept using jargon that they didn't understand and would often say things like, they must be right or she must be right because I don't know what they're talking about. And then those Facebook groups where they were both medical professionals and doulas, and people were like, fighting at each other. And then on the other group where they were only doulas, I would pick up the sort of aftermath of that, people saying, I don't know how to argue. And I thought, okay, I need to write this, because I was really very much aware that no one had written to the extent of analyzing the research that I had. And I think that might still be true today, even though the article is about 6 years old now. I've updated it again a couple of years ago to make sure when somebody interviewed me about it on a podcast, I was like, I need to make sure it's still true. And so it's one of my biggest pieces of work, because it took weeks and weeks of analyzing the research and making sure I'd covered. And I had it also reviewed by a lot of people in the field before I published it, to make sure that it was solid and I wasn't basically talking out of my arse about something, because I felt quite vulnerable going out there. And the funniest thing, publishing something that flew in the face of, I knew people in my world would be really happy, but I knew people in the other world wouldn't. And the funniest comment I think I ever saw on the forum about me, against me, about that article, was saying that I was as dangerous as Sarah Wickham. And I thought, I've arrived. Somebody
made it.
compare me to. I love that Sarah Wickham actually said that the placenta doesn't turn into a pumpkin at midnight. And so I've been very heartened over the years, because this is one of the most read articles on my blog, to have private message and emails from people saying that what I'd written, that lots and lots of professionals share it with their client, but also couples who are pregnant and who were facing induction of labor, like coercion around induction of labor, said that my writing helped them feel strong enough to stand up for what they felt was right for them. Yeah. That's really why I wrote this.
So what does the research really say? Let's start there, and then I'm sure I'll have a ton of questions.
And I think one of the things I need to address, which I've not really addressed that in that detail in the article, is are you familiar with the concept of circular research?
Yes.
Of course, research tends to go and look only at the thing we already believe to be true. And here, which is something that both Sarah Wickham and Dr. Sarah Wickham and Dr. Rachel Reed talk a lot. I love these women. Is that we live in a very ageist society, and also a society that likes to blame women's bodies for everything. When something goes wrong, it's because you're too old, too fat, not white enough. Like seriously, the level of blame: too small, too old, too tall, too thin, too fat, too not enough this, not enough that, and it's always so. The blaming of the placenta as aging, what people don't realize is a lot of the research goes around in circle looking at that, because they're convinced that's the truth. But actually, when you start to analyze that research that actually say that it packs up, is that they go under the belief, and then they go and look at the sort of little minute details of the anatomy and the molecular chemistry, molecular biology of the placenta, and they go, oh look, aging, oh look, aging, oh look, aging. And what I did, which I wasn't able to find anywhere else, is go and look at the same claims, but go and look at other research. Because what I remembered is that, for instance, you talk about cellular aging in terms of apoptosis, which is cell suicide, cell death. It's not just an aging thing. It's part of how the fetus nervous system is being shaped. So you can't say that apoptosis is just an aging thing. That's what I started with. And then I went through every single claim that was being made and looked at papers that had looked at it from another angle, not necessarily always in the context of the placenta, but who were saying, is reduction of telomere length always a sign of aging? Is this type of cells change always a sign of aging? Is the fact that you're seeing those kind of signs of what you interpret as aging, is it signs of change rather than aging? And the one thing that really blew my mind is when I updated in 2023, I discovered that there were papers that went in the way of what I'd started to conclude at the end of my own writing, which was, what if the changes that we see and interpret as aging, they are necessary for the placenta to detach at birth? And there's papers that actually show that's the case. The other papers that always go, oh, look, aging this, oh, look, aging that, even their own when you analyze it, not just as the introduction of the paper, but every single part of the paper, you realize that they're only talking about it as a theoretical. So before, ahead of our talk today, I went and I had a quick look at AI research, because now we've got tools like Perplexity and stuff like that that are fantastic. And I said, argue the pros and the cons of this topic. And they were like, pros are this, cons are that. So it's much faster to do when, with the AI tools we've got today, to actually go, hey, tell me about what's the truth about this. Is there arguments towards or arguments against? So the problem is most of the research is going towards the belief that it's aging. And then there's a lot more published research about that. And because people operate in this blind spot where they're absolutely convinced that's the truth. It's a bit like a parallel I often make is we blame co-sleeping for stillbirth, but we never blame cots for stillbirth. And yet the percentage of them that happen, they happen in the same, about 50% in each environment, but our society never goes and blame the cot, because the cot is seen as normal. And because we live in a society that loves intervention, medical intervention, always assume that it's a lot safer to do something than to wait, then of course people are spinning around in this little circle, being convinced that everything that's wrong is because women are older, they have more IVF, that kind of stuff. And when you really knuckle down and look at all of it, you realize it's not at all as clear-cut as people would have us believe.
So the aging of the placenta could arguably be said to be normal and expected aging, if you want to use that word, but you're
Yeah,
arguing that we just simply call it a change,
yeah.
basically a biological cellular change that almost matches your baby's maturation. So as your baby ages, your placenta should do the same thing. We wouldn't want a third trimester baby to have a first trimester placenta. We want them to have a linear experience alongside one another so that they can work in conjunction with each other. Is that right?
That's totally right. And the other thing that's really important to say, which I use a lot as a caveat in my article, is it doesn't mean that placenta do not go wrong. Sometimes they do. And that's very important to never go the sort of, it never goes wrong or it always goes wrong because there's something. But the idea that they systematically pack up after a certain number of weeks of pregnancy, that's what doesn't stand up to scrutiny.
Right.
So there are placenta that can pack up at 30 weeks pregnancy, and placentas that can be beautifully and juicy at 42 weeks pregnancy. Do you see
Or
what I
even
mean?
beyond.
Or even further. And then the other thing that people always talk about calcification as a sign of that there's something wrong. Actually, that's not true. There is, again, published research that says that calcification is not as simple as saying it's a sign that the placenta is failing.
So go more into that because I definitely have been in birth rooms where doctors have said, thank God your baby is here because
Me
look at
too,
all of
me
this
too. I've seen
calcification.
gritty placenta and midwives
Totally.
saying, oh yeah, good job, your baby came. And yet there's a paper, I don't remember the exact title of that I cite in so it's in my article where I go, oh, look, there's a paper that says that it's not at all as simple as saying that calcification. Basically, you can have healthy placentas with calcifications. And the other thing I don't share in the paper, which I found really interesting, was as I was writing this, I chatted to a friend who does placenta encapsulations. But she said to me, when I started, I assumed that the longer the pregnancy would have gone on, I would see like gray old placenta, like placenta that showed sign of not being healthy, as if you consider the calcification not to be healthy, but it's debatable. And she said that's not what she saw at all. She saw 42 weeks placenta looking really beautiful and healthy, and sometimes younger placenta not. Do you see what I mean? So it's oversimplification. And again, because we live in a culture that looks for signs of aging, doesn't like aging, then it's a very facile thing to say if there's calcification, it's systematically proof that it's not doing well.
So, what do you think accounts for that difference? Is it genetics? Is it blood flow? Is it nutrition? Is it blood pressure? Is it just our individual bodies and there are too many factors to even know what causes
Yeah,
calcification?
I think we don't know. That's what I kept telling to people who always choose to say it's as simple as if there's a problem, it's because your placenta is, stillbirth after very, very slight rise of stillbirth after 40 weeks or 41 weeks pregnancy are all caused by the failing placenta. I don't think that's true. I think it's just a very easy way to point at, oh, look, there's a problem there, and therefore that's what's causing the problem. The reality is we don't know. Like Sarah Wickham's talked about this and said it's maybe that babies have genetic condition that means their pregnancy lasts longer, and that's the genetic condition that's causing the problem rather than the placenta. Do you see what I mean?
Yeah, absolutely. So, do you believe that in some stillbirth cases, the placenta is to blame?
I believe that it's possible for placentas to not function optimally, and I've certainly supported women who had, for instance, twin pregnancies where one of the placentas wasn't working when there was like a blood flow reduction to one twins, and then thank God for medical intervention because sometimes the babies had to be born very early. So that I've seen. For me, it's the same duality, like black and white dichotomy between saying that you're either for natural birth and against the hospital, or as a doula, I've fought really hard for clients to get elective cesarean when it was the right, because they were denied that as well, when it was the right choice for them. Yeah, I've had clients move hospitals when the hospital was like, you don't need a cesarean, and they're like, there's psychological reasons that are just as valid as physical reasons for why a woman might choose to have an elective cesarean, because she's been traumatized by a birth, for instance, all sorts of reasons. Saying that it's either this or that, and it's very black and white. I think the thing is we try to believe that we know everything and we know why everything happened, and the reality is sometimes we don't know.
Yeah.
Just like most of the time we don't know why women miscarry. There's a lot of why women can't conceive, or there's like this really interesting, because we're all unique. I'm going to make a parallel here with when I first trained as a doula. I was told there was, well, not three, four types of pelvises. And now we know it's bollocks. Pelvises are like faces. There's as many different pelvises as there, like women's faces. But
Mhm.
people still believe that there are three or four types of pelvises.
Which is a scary thought because if your provider believes that, then they're automatically putting you into buckets
Yeah.
of whether you are going to be successful in birth or unsuccessful, which we know that your provider's belief around your ability to birth your baby impacts your birth experience almost more than anything else.
Oh, totally. Yesterday I bumped into a friend who's just had another child, and I said, how was the birth? And she said, great, it was natural. This friend, the first pregnancy, so she's got 4 kids now. This midwife took one look at her. She wanted to be in a birth center and said, you're too small. I'm not, she's a very petite woman. I'm not comfortable having you labor there. And she went upstairs and had a cesarean.
Oh no, I couldn't imagine that. So I'm pregnant with my first baby right now. And when I conceived, I was only 98 pounds, which is where that was my norm for the last 10 years of my life. 98 pounds was a very healthy weight for me. I have regular blood work. I am seen by my naturopath. I'm followed by my chiropractor, my acupuncturist, and I am a very healthy human. I'm just taller and thinner. And I guess I'm not like tall compared to other women, but I am just a very thin human. And oh my goodness, I couldn't imagine if someone had said that to me. It would have felt very discouraging. I've only had
Mm.
really empowering experiences. My hospital midwife, the whole hospital midwifery team has been super supportive of not only me, but also of me doing a home birth. And then my home birth team is absolutely lovely. That's why I hired them. But that's so discouraging. And it's hard when you have a provider who doesn't believe in you. It feels like an impossible feat to go against them because you know that the one person who is quote unquote in charge of your safety doesn't believe in your
No.
ability.
And that's another thing. When people bandy around the idea that induction reduces the risk of cesarean, induction of labor, we know that's not true. We know that the research doesn't show, the most recent research doesn't show that. We know in practice that this is not what is experienced. But I think it was either Sarah or Rachel, I think it was Sarah Wickham, who actually explained that because the system treats women who consent in a very different way to women who decline to have certain medical intervention, then it can be argued that there are less cesarean to women who consent to induction when that research was saying that. The newer research doesn't say that at all, but because doctors are less likely to want to do more intervention on the women who'd actually said what they wanted, followed the rules that they wanted to apply to her, than the women who decided to decline it. As a doula, I remember being as a client who was 42 weeks. She was on the cusp of being 42 weeks pregnant, and this obstetrician kind of towered over her and said, "We need to make a plan," meaning induction. "And what's your plan?" And my client said, "To give birth."
And stay pregnant.
Steam caved. Yeah, because they said, I've heard people say, "Oh, some women don't go into labor naturally," and I'm like, and what happened then? They stay pregnant forever? The most amazing story of longer pregnancy I've come across is a woman I trained who did doula training with me. She was tiny. I'm 5'3". She was like 5 foot tall, and she had 10 kids. And the first 4 were induced because she wouldn't go into labor by the prescribed date. And then after that, she has all 6 other at home at 43 weeks pregnancy.
There you go. It goes back to this arbitrary date, which was made in 1840 or 1860 by Dr. Nigel, who looked at 100 white peasant women who lived a very different life in a very different time than where we are now. And it's arbitrary. It's all based on our menstrual cycles as well. So if you have a shorter or a longer cycle than 28 days, the likelihood that your due date is wrong is really high. And in addition to that, you've got ACOG who says that about 5 to 5.5% of pregnancies are going to go beyond 42 weeks. And I think people really discredit that, or maybe they don't even know. That means that 95% of women are going to have their babies before 42 weeks, but only 95%. Where we think that 100% of people should have
So how many births a
due date.
year do you have in the States? Do you have those statistics?
I don't, but let me
Because
look
it's probably
that up.
per state. But in the UK, it's about 600,000 a year. So 5% of that's going to be a very significant amount of women. Are you trying to find some stats on births in the US now? Yeah, because 5% of whatever enormous number of women give birth every year in the US is not going to be just a drop in the ocean of women. It's going to be hundreds, thousands of women. And the thing that really blows my mind is I have supported a lot of women who conceive through assisted fertility. And so they had a piece of paper that says exactly when the baby was conceived, but still the sonogram would say something differently, and they would still be told, your due date is bloody blah, even though they actually have a medical piece of paper that says otherwise. Do you see what I mean?
Yeah, absolutely. Okay, so I found the stats.
Yeah.
This is, let's see if I can't find the year for this. For 2023, we had 3.59 million births. So let's round that up to 3.6. And then if you multiply that exactly by 0.05, you get 179,800 births. You guys, we're talking about almost 200,000 births in just the US every year that would fall into that category of going beyond 42 weeks. That is insane. And then we walk around and everyone at 39 weeks is curb walking and drinking the pineapple juice and eating the dates and having the sex and eating the spicy foods and bouncing their bladders out on their birth ball, trying to get their babies to come by 40 weeks, knowing good and they're not going to come by
I
then.
know all they're doing is stressing themselves out. And I've now realized also one of the reasons I wrote about this topic is because my first birth was at 40 plus 14. And I was very lucky to I have a longer than average cycle, and my husband's from Hong Kong, and my husband's mother, I'm French, my husband's from Hong Kong, we met in Scotland, as you do. His mother said that she was also pregnant for a very long time. So I always ask my clients, is there a history of long pregnancy in your family? Because it runs in families, so there certainly is a genetic element to that. And I basically had a very lovely Scottish midwife within the health system who was, what I didn't know at the time, because I'd not done all the training I'd done, was secure enough in her practice to basically go against guidelines and actually did nothing but reassure me. But everybody else, I remember going to a shop when I was like 10 days past the 40 weeks, and the shopkeeper saying, when was the baby due? I said, the baby was due 10 days ago, and people would go, get out of my shop. No, they didn't say that, but their face would really say, oh my God, get out of my shop, because they were worried you're gonna... I entertained fantasies of like bringing a bottle of water and splashing it through my trousers legs on the floor. Just for... I can't do that. I'm just a what you see is what you get person, but... People with my parents stopped going to their choir practice because they were due to come and visit from France, and everybody was saying, "You're still there. She's late." What do you mean she hasn't had a baby yet? That she has a thing. Somebody made a website called HasSheHadABabyYet.com, and you click on that, and it goes no, because one of the really annoying things is that because everybody behaves like there's something terribly wrong with you when you pass 40 weeks pregnancy, even though we know that it's a growth curve, and the peak actually for first-time mother is at 41 week, not 40. That's an average. It's normal for some women to birth at 37 weeks, and it's normal for some women to birth at 43 weeks, and everything else in between. And then, like you said, I've seen the women making themselves sick from drinking too many juiced pineapples and stressing over too much. And then the system also, in my city, in Cambridge, the birth center has a rule that if you go past 42 weeks, they don't let you in. Although I've managed to, I think you'll like hearing that, I've managed to help clients bend that rule by saying, it's very simple. You can just say, I'm going to stay at home then. And then suddenly the birth center door magically open.
Suddenly they say, oh, actually, come on in. We'd rather you have your baby here, which is also so wild. Why would you rather someone be in a medicalized system when home birth is just as safe, arguably safer for a low risk woman? No, you
Yeah.
mentioned do longer pregnancies or going past your due date or even post date, which is defined as 42 weeks and beyond per ACOG. I don't know what niece or nice says
Yeah.
in your country, but post date in the US is post 42 weeks. And two other things that I want our listeners to walk away with is that if this is your first baby, you're more likely to go past your due date, even beyond that 42 weeks. And oddly enough, if you have a male boy, if you're pregnant with a boy baby, you are more likely to go past your due date and even past that 42-week mark. And so if you are all three of those, you know that long pregnancies run in your family. This is your first baby, and you're pregnant with a male baby. Chances are you are going to see your due date come and go. That estimated due date, remember, it is an estimation, it's not a expiration, but chances are you're going to see that date come and go and you will not have met your baby by then. And so I just want to reassure you that you may fall into that category of that 179,800 births that might go post date, which is absolutely insane.
And again, I always
Like
think
that.
if we gave a due month, when we didn't have all the tech, people would go, baby will be there in the spring. And then nobody would lose their shit over. They would just, wait and see.
So that's what I've chosen to do. The only people that know my actual due date are my husband, my home birth midwife team, and my hospital midwife team. We've chosen to tell everyone else in our family, including our parents, just a month that we are due in November and our baby will be here sometime in November. And that may mean that they come late October or they might come early December. But either way, we have not cornered ourselves into a specific date. And it protects me mentally and emotionally because the last thing I want is for people to be texting and calling and asking, like, where's the baby? Have you had the baby? Is the baby here yet? And I do understand it's all out of love and it's eagerness. And this is the first grandbaby on both my side and his side. And I know that this baby's going to be so loved, and people are just so excited to meet them. But to protect my own self and my own energy in this sacred space of allowing our baby to choose their own birthday, I wanted to make sure that nobody had a date that they were attached to, and therefore they were putting those fears or expectations onto us. When, in my opinion, a due date is quite an arbitrary date. It's nice to have a due date because all of our measurements and everything are compared to other babies with that gestation. So it is important in some regards, but as far as expecting your baby to show up on that time and that date, very inaccurate. So I have a question about understanding whether your placenta is actually functioning well or not. So we've got this idea that the aging placenta is a myth. It's a fallacy. It's a falsehood. How do we go about checking our placenta to make sure that it's healthy if we're being told by our healthcare team, oh, your placenta is going to give out or it's going to stop working? Where do we have control in that conversation as consumers?
It's a tricky one because the only okay, we need to look at two angles. One of them is that I really believe in women's instincts. So I think it's really important for the mother never to ignore if something doesn't feel right, and vice versa if it feels actually. So I often suggest to women that you can consent to an induction, but if you wake up the next day and you think, actually, I don't want to go through with it, just cancel the induction. You don't have to commit to a decision 10 days in advance. So I think that's really important. How did we get to a place where we've been made to believe that we can only feel what's happening with the baby through a machine? Because this baby, you're pregnant right now, you can feel this baby. It's contact 24/7. And women usually know when something's wrong, and usually women know when something's right. So I know it flies in the face of medical belief, and some people might go, this woman is really dangerous for making this advice. But as a doula, I've always been, whenever the women was saying something doesn't feel right, I would say, go to the hospital, get checked in the hospital. The problem is the only option to check is usually done with an echography or sonogram. And whilst I believe that some aspect of it, like blood flow, are actually probably sound, the sort of other aspect, which is to look at calcification or to look at, for instance, the amount of amniotic fluid that I've already mentioned, the calcification is debatable. That is actually a sign of aging. But the problem is that there are other ways to measure the baby's size and the amount of fluid around the baby. It's massively inaccurate at the end of the pregnancy. And actually, most of the time when women decide to go for what's, I don't know if you call it the same in the US, but typically they should be giving three options. The option one would be to be induced, the option two would be to have a cesarean, and the option three, or whichever order you want to put in, would be to wait and see if labor starts by itself. It's called expectant management in the UK. And when women choose to, and any good healthcare worker, any good obstetrician who really are women-centered, they know how to share those options with women in ways that are not emotionally biased. So I've seen wonderful obstetricians at my hospital who go, hey, we know the research is full of holes, but that's all we've got to go with, and we want to we're here to decide whether you want to wait, whether you want to be having your labor induced or whether you want to have a cesarean. In reality, a lot of the conversation don't happen that way. But if you choose to wait, you should be offered, here in the UK, you should be offered what they call every few days, you should be offered to go in the hospital and have a sonogram, have an echography. Sorry, that's a French word now. I'm trying to speak in American term rather than English one. And what is a scan, they call it. And sometimes they also record the baby's heart rate with a CTG monitor for 20 minutes. And people are made to believe that this is all like super technical, guaranteed to tell you this, guaranteed to tell you that. But the fact is, it doesn't really, all it's doing is telling you that at that very moment in time, the baby seems to be okay or not okay. But the problem with that is that there's also research that shows that it leads to bad outcomes sometimes, because women are feeling something's not right. They go in, they measure the baby's heart rate, they tell them it's fine, and then women ignore their instinct instead of. So I've always found in the 10 years I've worked as a doula that it's a very complex, and you should always listen to what the woman is feeling. In my time, I've seen women who have planned the home birth changing their mind at the last minute or wanting to be in the hospital at the last minute, and then something happened that showed that they'd done the right thing. Something very unusual happened. And vice versa. I've seen women who were planning to go to the hospital actually saying, I'm not going. And the people in the hospital being really flustered, and the women shouting, I've made an informed decision. All right, then we'll send you a midwife. So it's very difficult to navigate, because what we're being made to believe is that the science is faultless. But that's not true. We know that's not true. We know that it's inaccurate. We know that CTGs don't improve outcomes, for instance, and yet people keep using CTGs like it's some kind of magic machine that guaranteed to protect everyone. I think it was Sarah Wickham again who had written an article where she said that the whole CTG thing was like rearranging the Titanic's deck chairs. Because we've got research as far as the 1990s that say that all CTG do is increase the rate of cesarean. And the more CTG are being invented, more research, it still shows the same thing since the 1990s. And then when the research comes out, people, instead of going, we should really look at whether it's the right thing to use this machine, they go, we need better machines.
As women, we've been traditionally conditioned to not trust our bodies, to put our trust into outside sources, to put our trust into machines, to override our instincts and what our gut is telling us, because the electronic fetal monitoring is confirming that everything's right. I interviewed an obstetrician here in the US that does a lot of placental research, Dr. Heather Florescu, and you can find her in episode 274. And we talk about placental health. And she talks about the very same concept that when you go in feeling worried about something, even if the machines show that everything is fine, if you don't feel fine as that mom, as that patient, as that pregnant person, then you should not leave. And as the provider of that patient, you should not kick them out the door saying everything is fine. We have confirmation, because we have stories that you go in and exactly like what you said, it tells us right then in that snapshot, and then something happens later and that mom's intuition was actually really spot on. And so it was really fascinating to hear Dr. Florescu say, until your patient feels safe and secure in your findings, then your job is not done. And I think that is just so fascinating. Another thing, and listeners, I know you probably know what's going to come out of my mouth, but I would be remiss if I didn't say it, because it is such an accurate tool. But if you're not counting kicks past 28 weeks, you should be doing that. Download the Count the Kick apps. You pick the same time every day. Wait for your baby to get to 10 counts or 10 kicks, and that is your baby's normal. The outdated version is 10 kicks in 2 hours. We know that is not accurate for every baby now. We know that each baby has their own norm, and so we are still using the 10 kicks but it can be in 5 minutes, it can be in 2 hours, or anything in between. So just make sure that you are up to date and familiar with other ways that you can keep up with your baby's well-being, because the minute that you start to put your reliance and your reassurance into machines and people outside of your own instincts is the time that you lose all control. You need to be the one that is tapping into your instincts and making decisions for yourself, because you're the one who's connected to your baby. You're the only one that is truly connected to your baby. You have a direct lifeline between you and your child. And like you, Dr. Sophie, I really believe in a mother's intuition. I really believe that when a mom feels like something is wrong, most likely something is absolutely wrong, and that we should tap into that and listen to it.
Yeah.
Okay, so I have a question about first-time moms versus subsequent pregnancies. Is there any data that shows that with your second, third, fourth, fifth, 10th baby, that your placental health is different, either better or worse?
Good question. I can't remember if I've come across any research on that. I know that placentas tend to get bigger the more babies you have,
Okay.
but I've not looked or come across any research about showing that placenta has come. Is that something you've come across?
No, not at all. And it would make me I tend to believe that every pregnancy is individual. And so each pregnancy, that baby is going to have their own individual health, and that placenta is going to have their own individual health. Now, are your past pregnancies insight to this pregnancy? Yes, possibly, but it also lends itself to the situations where you've had gestational diabetes in your two pregnancies prior to this, and you're on your third baby and you don't have GD this time, or you've had a baby previously and you had preterm labor and your second baby goes to 42 weeks. So we've got situations where, yes, prior pregnancies are good insight and they're data for us, but they are in no way a telltale of what will guaranteed happen in this birth. And I think that is a place where sometimes that nuance is lost. The hospital system can sometimes make you feel as if this happened in your last pregnancy, so it's absolutely going to happen in this pregnancy. Another place that happens a lot in the US hospital system is hemorrhage. If you hemorrhage in your last
Yeah,
birth,
yeah.
then you're absolutely going to hemorrhage in this
And
birth.
again, nobody's looking at what did the caregiver do in the first birth that caused that. Because they're saying it's not over till the fat lady sings.
Yep.
Yes, it's not over until the placenta has been born. And one
Mm.
of the things that has frustrated me immensely as a doula was to see that when the moment the baby arrives, people don't respect the bubble, don't respect the sacred.
Yeah.
They hustle and bustle and they want to cut the cord and they want to put a hat on and they want to do instead of letting the couple or letting the family get to know their baby. And so that creates stress. Do you see what I mean? And not recognizing that actually it's safer to not create adrenaline in the room until the placenta has been born. And that, I believe, causes some of the problems that
Well,
we
not
see.
only that, but tugging on that placenta in such an aggressive and violent way, pulling it away from the uterine wall inappropriately, can absolutely cause hemorrhage. Now, is
Yeah.
that to say that there's no scenarios where traction is appropriate? Absolutely not. We know that when a hemorrhage is happening or at the beginning stages of increased bleeding, once that's recognized, traction can be helpful. But it does not mean that traction should be a standard practice. Why? Because the placenta is very smart. I said at the beginning of the episode, she's very wise. She knows what she's doing. She knows to come when you conceive, and she knows that her job concludes once your baby is born. And I believe that the placenta and the uterus in your brain all work together. They're communicating to say, my baby is born. The cord has drained. The uterine walls and the uterine muscles are contracting. Now my time as your placenta has come to an end, and I am safe to release. Your baby is breathing on the outside. All of my blood has now been transferred to your baby. I am good to release. And I believe that when we preemptively pull that placenta away from the uterine wall, we actually cause way more harm than we do good.
I also, in my article, when I conclude at the end that there's a possibility that there's a process that is interpreted as aging that needs to happen, and then if that's the case, what do we do to the ability of the placenta to detach if we induce when that process hasn't happened yet? And that, as far as I know, has not been studied. But it's made me wonder. Because the other thing I found, as I'm listening to you now, I'm thinking of stories of birth, and the most mind-blowing case I've ever seen was there was a long second stage. The baby was like at the perineum for the longest that I've ever seen. What I believe now is there was probably some undiagnosed shoulder dystocia, but not severe. And when the baby was eventually born, luckily there was a wonderful midwife in my local birth center who was completely on board with it, completely nonplussed. The cord pulsated for 90 minutes. I have never seen that. The midwife kept checking it, saying, yeah, still pulsating. So the baby was on the mother's chest, her bleeding was fine. The midwife did put absolutely no pressure. And I kept thinking, this baby needed this to recover. So if we clamp early, what the heck could have happened to that baby? And I've even heard, and I've not seen myself, but midwives telling me they've seen cords still pulsating when the placenta has actually been born.
Wow.
Because the only way to know you've had a truly physiological third stage is to wait until the placentas come out to cut the cord. Now, the other thing, we're talking about wisdom, the other thing that has also really blown my mind is I supported a friend of mine, and she had a lotus birth at home. And after a few hours after the birth, which was absolutely gorgeous, it was the first birth I dreamed that, actually, she handed me her son to hold for a bit. And I was like holding this baby, and I looked at her and I said, he's not there. And she said, yes, when you have a lotus birth, the soul dips in and out until it's really ready to incarnate. And I can't tell you why I could feel this baby was not there, but I could. And my friend was like, yeah. There's all sorts of weird and wonderful sacred magic stuff that happened around that time, that people who do work in this field as true space holders, and I'm talking about birth midwives and doulas, witness absolutely amazing things. And then people who work in the sort of only the medical realm, looking at it from the medical angle, and it being just flesh and blood and not spirit, they don't see or believe in any of that. I've heard of midwives. There's an amazing story I came across on Facebook where this midwife said his baby was born, but it wasn't quite like fully alive. And then this two little girl with the sisters of the baby said, "Oh, brother, we've been waiting for you for so long." And then boom, the baby suddenly came alive. If it was not quite there yet, and then when the little girl happened, it kind of
Ushered him in.
Yeah.
Yeah. That is so cool. I'm definitely a very spiritual person. I believe that our babies are really spiritual. I've had past guests on the show to talk about spirit babies, and I believe that our babies choose us. I don't believe it's happenstance. I believe that when left to their own devices, our babies will choose their own birthday, and that their birth, when left to their own devices and unhindered, their birth is their first storytelling event. They will have the birth that they need, or maybe it's the birth that you, as their mom, needs, and they know that it's their first lesson to you as your child, because we all know that motherhood is nothing but a big teaching moment for the rest of your life. You are constantly learning in motherhood. And I feel super blessed to be on this journey, that I am about to embark on this ever learning journey, and that the first time my baby and I are going to really have a lesson in one another is going to be at birth. Not that I'm not learning them now, I certainly am. And I can feel that they're learning me. And we've got our communication styles, and I talk to my baby every morning and night. And I had a medium on the show a couple of shows back, and she said that my baby really loved to hear me talk. And so I've been talking to them a lot more. And we've got rituals that we do together, and it's just super fun. But I do believe that your birth is a rite of passage for not only you, but for your baby as well.
Yeah.
Okay, I have a question about racial or cultural differences. Do we see placental health vary in different races or in different countries or cultures around the world? Is there anyone that's listening that should know that they may have increased risk factors or influences based on their personal factors?
Really good question. So I'm going to be very and say I do not know of personally of research on that front. What I do know is that because in the UK the risk of dying in childbirth is 5 times higher if you're a woman of color
It's the
than
same
if you're
here in the
white.
US. It's the same here in the US.
And the response to that from the NICE guideline in 2021 was to say, let's induce all the women who are not white at 39 weeks.
Wow.
So I wrote to NICE, thousands of people did, to write, this is ridiculous. Because when they issued the new guidelines in 2021, the draft 2021, I think the new guideline came out in 2022. Or was it the following year? I can't remember. They suggested that anybody who was beyond 35, had BMI over 30, was not white, had used any form of assisted fertility treatment. I can't remember what the 5th category was. That meant that when you looked at the percentage of the population, there was almost nobody left. And there was an uproar, and people just basically went and wrote, and they watered it down. But it's still in the UK brought the guideline from 42 to 41 weeks. So now women are being offered induction. So I think circling back to what you were saying, the attitude of your caregiver is the biggest risk of how you're likely to be treated rather than the actual risk. So people, because institutionalized racism and colonialist mindset are still extremely present in Western healthcare, and people are not actually aware that they are operating under this bias. I remember I supported a woman who was a woman of color who had conceived through IVF, and because she was adamant she wanted a home birth, they went and dig up in her old medical record and basically brought that against some past history of mental health against her without her consent, to try and force her to consent to an induction of labor. And luckily she was a very strong, powerful woman. She basically she not only fought back, but actually personally threatened the head of midwifery with legal action if she didn't provide a midwife for a home birth. But that, both through my own experience and through the experience, I've mentored quite a lot of doulas, and I've seen time and time again that I'm not aware that there's any research showing them. I might be correct. I hope people correct me if I'm wrong, but that any research showing that you're more likely to have a placenta failing if you're of a certain ethnicity. I'm aware that there is some research, which again I think is debatable, saying that if you've had any form of artificial conception, you're more likely to have problem with your placenta. But again, I think that's also open to interpretation. And same with age. Older women are again considered to be, they are very likely to be offered more interventions. But the fact is, if you're not white, you're much more likely to be treated in a way that's, you're going to, with less respect, with less belief in what you say. And I think that's probably more impactful than any form of research that would show anything about. I'm really not aware of any research that says that placental function. It's the same with women who are plus size. As Sarah Wickham's written a recent book about plus size pregnancy, And people assume, just the same way as if you're a big woman, people assume that all your problems, you're not going to be able to give birth, you're not healthy, you're not this, you're not that. And we both know that BMI is not good science.
It's just BS.
It's completely like missing the mark, because it's not at all representative of whether the person is healthy or not. But fat women, big women, are systematically going to be treated like they can't give birth. They're being told in my country that they can't go into a birth pool in case they can't get them out if there's an emergency. There's the number of it goes beyond that. It goes also with the sort of idea that if you've got pelvic girdle pain, you might not be able to get in and out of the pool, and then being refused access to certain birth options based on your body shape, your medical conditions, your race, your ethnicity, yeah.
I want to circle back to that, but before we do, I'd like to hear you talk about the debatable points of placental health with people who are pregnant over 35 and have assisted reproductive health.
Yeah.
So someone who is conceived via IVF, what's the debatable points there?
So again, a belief that you're more likely to have your placenta pack up if you're older, or if you're conceived through IVF, and the risks are always really minimal. Do you see what I mean? Compared to how it's presented. And I've not dwelled down into the details of the research in the same way that I've dwelled down into the details of the research around the concept of placenta aging as a general population thing. But again, it's the same as if you're older, you're automatically assumed to be at risk. So your caregivers are very likely to just want you to have a cesarean or induced labor early, when actually the evidence behind that is very debatable, and they're not giving the women the choice. So the most amazing story about that is a friend of mine became unexpectedly pregnant at the age of 54. She was a grandmother. And of course, the first thing the obstetrician said is, we'll induce you at blah, 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 or we'll do an elective cesarean. And she said, no, I'm having a home birth. And I would have liked to be a fly on the wall to see that obstetrician's face. But the idea that you're systematically failing, your body is failing, because who's to say that a woman in her mid-40s who's really fit, who eat healthily, who has a really good lifestyle, is less healthy than a woman in her 30s who eat very unhealthy food, doesn't do any like this. Again, we always look at an average, and there's this assumption that you're systematically less healthy if you're older, if you have conceived through assisted fertility treatments of any kind. And again, because what happens is most people do no antenatal education. So one of my theory of why the system is so coercive is because in the UK, less than 10% of people have any form of antenatal education whatsoever.
Wow.
That includes people who have antenatal education inside the system, which I've been to those classes. They tend to just tell you, this is how we do it, and this is what you should do. And there's much less of them now, because since the pandemic, the system is really badly underfunded here, and it's about to get a lot worse. So there's very little in terms of education within the system. But most people do no education, so they rock up and they just do what they're told. So that also means that a lot of the health professionals inside the system get de-skilled at facilitating informed choice, because people tend to just hand over We touched on that earlier. We live in a culture that from very early age teaches us that the knowledge lies outside of ourselves. Yeah? And you hand over your knowledge, your choice decision-making to authority figures who know best what's right for you. But guess what? They're not living your life, you are. They're not the one who are going to live with the consequence of your choice. You are. Because the system is built that way, and there's a lot of coercion in it, and the system itself is not really aware of all that is doing that. You see what I mean? In the UK, for me, it works. This maternity care works like a medieval church, because nice guidelines are issued at national level. Then each hospital issues their own guideline, because we've got this thing called postcode lottery, because different hospitals induce labor at different times. depending on where you are. Because, of course, each guideline, the NICE guideline, which is already biased because it's created by people who are usually of the leaning towards the idea that doing something is better than not, and all the research is always true. There's a obstetrician friend of mine in London who's written a paper a few years ago that showed that maternity care is the least evidence-based field of medicine, and only 9 to 12% of maternity care guidelines are based on grade 1 evidence. But people assume, 9 to 12%, then it very quickly filters down to opinion pieces. So everybody's convinced it's all very strong and evidence and stuff like that, but it's not at all as simple as that.
I recently read an article, and I'll see if I can't find it for you guys. I am not sure I'll be able to, but it was stating that maternity care is one of the only non-consensual pieces of the hospital. So you would never have a non-consensual cardiac surgery, or you would never have a non-consensual knee surgery or pulmonary surgery. Whereas in maternity care, you have this assumed consent, and because you've showed up to the hospital, they assume that you are okay with everything, and therefore many of the practices are unconsensual, and it's just the norm in maternity care. I have a question about when you would think, or what signs you're looking for that would indicate a placenta that isn't doing well, other than maternal intuition.
We don't know.
Yeah.
Because I've not seen, obviously, bar the extreme case of placenta previa and having vaginal bleeding, in terms of a healthy, like a normally implanted placenta. Because what I would say to women is just always look at change in baby's movement, or your baby's rhythm of movement, or something that tells you something's not right. But then there's so many different things that could cause, might not necessarily be anything to do with the placenta. So unfortunately, and I always say the same thing about people wanting to know when is the labor going to start. I would be extremely rich if I had a way to go, your baby's going to arrive on that kind of time. But as a doula, I also know that the more I worked with women and the closest connecting emotionally I was to a client, the more I was tuned in and often knew she was going into labor before I received a call, to the point of having contraction myself. So there's something there that speaks of the magic but we'd like to have all this kind of guaranteed reassurance, and the fact is, even with the technology we have today, because again, with the very difficult debate around aging placentas, is people are convinced that if they did induce everyone early, somehow they would avoid all stillbirths, and we know that's just not true. And we know we do a lot of unnecessary interventions on women and babies who don't actually need an early labor or an elective cesarean, because we are in this fear that, because of litigation, and there's this fear that if we don't do, it's always better to do something, better safe than sorry, as people say.
And what about babies who have shown a great decrease in their growth chart? So something like IUGR, FGR.
Yeah, that's very different. Yeah. If there's a sign the baby's not growing. I remember when I was very new to this field, I was thinking, it makes no sense to induce a baby if it's too small, but because you want to keep it growing. But of course, if there are signs that the baby's not growing well, that's a very different story. And again, the paradox of the aging placenta is that women are being told both that your placenta is packing up, but also if you don't get induced, your baby is going to get too big.
But you can't have both.
You can't, either your placenta is not working well, or your baby is getting too big. If your baby is getting too big, then chances that the placenta is working well. It's like, the problem is people always wanted to make what is actually a very complex topic, and every single unique birth and pregnancy is a unique kind of ecosystem. People want to make it into very simple, it's like this or it's like that, and then they don't listen to women. I think that's the main thing. If people had, because again, it's going to feel very different for someone if they're being offered, really genuinely offered. I don't know how people do it in the US, but people here don't actually offer an induction. They just go, I'm going to book you for an induction. And people don't realize it's not an obligation. The number of times I've heard people say, what do you mean you don't have to be induced? When I started teaching doula courses, doulas who had that themselves, this type of birth, would get absolutely shocked because they'd often not debriefed their own birth. And then they would go, what do you mean you didn't have to be induced? It's not the law. I've heard a midwife say, you have to be induced, it's the law. There's no law about induction in the UK, not yet anyway. And I know in the UK it's very different to the US, because in the US you have fetal rights and in the UK we don't. It's very different legal terrain.
Wow. Yeah. Okay. That leads me to my very last question, which is we're in a for-profit healthcare system here in the US. You are not. You're in socialized healthcare that does not necessarily prioritize profits over people. Why do you think we're seeing similar problems, even though our healthcare systems are set up incredibly different, arguably opposite?
Yeah. It's, for me, what I see above the board in the whole of the modern Western world is an entire politics system, education system, and medical system that's designed on the patriarchal model of coercion. And that's got nothing to do, the finance is almost irrelevant. Although I know that that plays a role as well, because obviously people make more money from certain medical intervention. And it's more convenient for them to schedule a cesarean than it is to have any predictability. That's why you end up with places like Brazil, with some hospital have 100% cesarean. But here in the UK, we went up from, in the period of COVID, we went up from 10 points of induction, or 10 points of cesarean. Some hospitals have cesarean rate that's above 50%. Some hospitals have cesarean rate that's above 55% for first-time mothers. And you cannot possibly scientifically say that in those 5 years the population changed enough for it. And people keep justifying, saying it's about the population getting older, fatter, it's women's fault. You can't argue scientifically, but meanwhile, the people keep saying we need to do this intervention, otherwise we'll have more stillbirths, but the stillbirth rate...
It's the same.
Yeah, I published a blog where I analyzed the stillbirth rate between 2010 and 2020, and as all the intervention went up and up, and stillbirth rate is... You can't...
Showing that induction and C-section does not actually improve our stillbirth rate.
But people are convinced that it does. I love Rachel Reed's in her book. She says that the way we use CTG monitors, given it doesn't improve outcome for either mothers and baby, and the science is like black and white on that. She said it's a bit like the equivalent of using some kind of, how do you call it? Amulet. It's the ritual of the Western world. Because whether we're talking about the US, we're talking about the UK, we're talking about Europe, France, where I'm from, we're talking about Australia, it's the same across the board, right? The rates keep rising, the rights of women within the system keep shrinking. My husband is from Hong Kong, and he says, when you push the pendulum too far one way, it always swings back the other way. And when I started my doula career, like 15 years ago, I was convinced that in my time I'd see people embrace a more holistic model of birth, a more people-centered model of birth, and all I've seen is the exact opposite. And I see the same across medical care, but I see the same across education. I don't know what it's like in the States, but here they keep shrinking the rules. They keep like going back in time almost to like system that should belong to the Middle Ages instead of belonging to 2025. Because when I'm quite spiritual too, and I believe humanity is going through some major awakening, and when the system is collapsing because it can't keep functioning like that, then it tries to control everything to an inch of his life. And that's why we're seeing this thing where they pretend it's for saving lives, they pretend it's for, but that doesn't stand up to scrutiny. the argument. It doesn't stand up to scientific scrutiny. But the really interesting thing I found is when I've tried to discuss those things with people who were not open to this discussion in the system, is that they are unable to, because I don't know what it's like in the US, but most people in the UK, the way the system is designed, is not designed for them to have independent thought. It's designed for them to do what they're told. So then, the story of the man gets yelled at by his boss, comes home, yells at his wife, and the wife yells at the kid, and the kid goes in the garden and kicks the dog. That's what we see in trickling down in maternity care. Is people inside the system are actively punished if they don't follow the guidelines. And so it's almost they become unable to have joined-up thinking. And questioning is not part of it. So when I've actually tried to bring the topic where I've been today, aging placenta, into the conversation, instead of having an actual intelligent conversation, people said, that's not what the guideline says. But they've never gone to look at the science behind the guideline. Do you see what I mean? They've never gone to look at whether the evidence is solid. People just do use the machines because that's... And they really genuinely believe. I don't think they're bad people. They genuinely believe that this is the best thing to do, the right thing to do. And it took me years as a doula to understand, because I was a scientist. I've always had a very inquiry mind. I want to know why we do this. I want to know what's the logic. And if you looked at the opposite, the other options, and blah, blah, blah. And keep meeting people who just don't have that way of thinking, because the system doesn't want people. In an episode of the Midwife Cauldron, I remember Rachel Reed saying there's 3 types of midwives: the one who like the rules in the system and believe that they're good, the ones who don't agree with the rules but disrespect them covertly, and the one who don't believe the rules and disrespect them overtly. These are removed. So it's very tricky, because I still believe there are really good people inside the maternity care. I've met some, and I don't believe that everybody who's operating but inside the system is there to get you. But the people inside the system are not aware that the water they're swimming in is polluted, not in a good way. There was an article written by Marston Wagner, who was the women's health person in the WHO. He's passed away now. And it was called Fish Can't See Water, The Need to Rehumanize Childbirth. It's a published article in a scientific journal. That was written in early 2000, and it's still as current as ever, everything he talks about. One of the reasons why I started to move away from being a birth doula is because I became very acutely aware that my energies were better used not fighting against the system, which I felt I was doing incrementally. That used to be just the odd client, and it felt the last few years that's all I was doing, wielding a sword and a shield. I started to realize that supporting women more globally to be able to access their inner wisdom was a better use of my energy. And actually, basically, I felt like when I realized that I was 52, I'm 55 now, and I just thought I want to be an elder at the back of the battle line. I don't want to be at the front of the battle line anymore. And that's why I started getting more into spiritual approaches around this, and especially, I know it's going to sound like it's just a woo-woo thing, but the reason I wrote this book that I've got coming out in September called The Beat of Your Own Drum, and there's an entire chapter about drumming and birth in there, is that there is actual really absolutely brilliant science that shows that drumming increases endorphin, drumming changes state of consciousness, drumming puts you into a less anxious, more relaxed state, and that women told me that they felt it helped with pain, and that they were able to basically go to a state where they could really communicate with their babies. And I've supported in the book, the stories of women who have had 3 births and basically used the drum as a way to communicate with their baby. Like you say, you're talking to your baby morning and night. And after, Joan Hardwick Collins says that after using drum journeys for a few times, women no longer need the drum because they know what to do to actually communicate directly with their babies.
I love
so
that.
I think we need facilitating more, and it's hard when you've always been brought up in a sort of very rational, only functioning from the head kind of stuff. To pregnancy might be for some women the first time that their body and soul is asking them to actually go in and ask themselves what they want, as opposed to going to somebody else and ask them to tell them what to do.
Tap into your intuition. We talk about that all the time in this community. Is you have that wisdom inside of you. You don't need someone else to tell you the answer. You just need permission and safety to go within yourself to find what that answer is. Oh my gosh, Dr. Sophie, this has been amazing. This has been such a good conversation. I really appreciate your wisdom and your knowledge and you being so open and forthcoming with everything that you have researched and collected and sharing it with us so freely. Where can people find your books and order them and listen to your podcast and connect with you and learn from you? What are all of your resources if people wanted to connect with you?
Yeah, so the books, I've got two. I've got Why Postnatal Recovery Matters, which is published by Pinter and Martin. I believe in the US you can get it from Amazon, but I'm not entirely sure because if people want to get it and they can't, certainly I know it's available on Kindle. The paper copy, I'm not entirely sure. People are welcome to contact me if they struggle to find how to get a paper copy. This book, The Beat of Your Own Drum, is being published by Womancraft Publishing in September 19th this year. It will be, in the US, it'll be distributed by a very esoteric publisher called Red Will Wiser. So it'll be available in the US for people to purchase and read. And then if people want to find my website, it's sophiemessager.com. I'm sure you'll put that in the show notes because I'm not going to spell my name. People often write the English version of my name and then they can't find me. It's Messager, the French spelling, not messenger. And then on my blog, what I always say to people is I suggest you start with, on my website, there's a lot of stuff. And I always suggest to people they start with my blog because there's 250 articles about birth, life, all sorts of topics. At the moment, it's very leaning towards drumming, but there's tons of other things. Often people find my articles more by Googling my name and things like the myth of the aging placenta. But I've got so many birth stuff in there as well. And otherwise, people can also find me on the usual social. I'm on Facebook, I'm on Instagram, I'm on LinkedIn, I'm on YouTube. And my podcast, which is available on Spotify, YouTube, and Apple Podcasts, is called The Wisdom Messenger.
Oh my gosh, I love it so much, you guys. I hope that you enjoyed this conversation as much as I did. You are not new to the conversation of our crumbling system, and we really always acknowledge that the healthcare system has done this to themselves. They are continuously taking away our rights, even though they say they want what's best for us. However, they can't respect or honor our autonomy, and they don't trust us to make decisions for ourselves. We see that healthcare providers that do stand up for those things are retaliated against and removed from the system, and that only hurts us as consumers of medicine. You guys, stay vigilant out there, ask the hard questions, and don't take guidelines as the laws, but just as they are, suggestions from what the system thinks is best for you. But I want to reassure you that you very well may know better for yourself. I believe that. Sophie believes that, and I want you to believe that as well. All right, y'all, I will see you in the next episode. Be sure to follow Sophie on social media, and you can find me at Tranquility by Hee and at the.birth.lounge. Until next time, head to your app store and download the Birth Lounge app for evidence-based childbirth education and data-driven postpartum support delivered straight to your phone. Bye. Thank you so much for tuning in today. I love hanging out with you, and it is an honor to be your go-to gal when it comes to preparing for your baby. If you've enjoyed today's episode, please leave a 5-star review and tell others why they should be listening to the Birth Lounge podcast too. You deserve to have a birth that you love with a provider that values your autonomy and respects informed consent without all the trauma that you so commonly hear about on social media. New episodes air every Wednesday and Friday. Hit that follow button so you never miss an episode. I'm Hee, and this is the Birth Lounge Podcast.